Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent sponsorship from Johnson & Johnson.
This program is presented by Medscape Education Global.
Hello, my name is Enriqueta Felip. I'm a medical oncologist working at Vall d'Hebron University Hospital in Barcelona, Spain. And I'm going to review the latest clinical data in the first-line setting for patients with EGFR mutation advanced non-small cell lung cancer presented recently in major meetings. So I will start with the Mariposa trial. So the Mariposa trial included patients with EGFR activating mutations, and patients were randomized to receive amivantamab plus lazertinib versus osimertinib. There is a third arm, lazertinib, that was included to analyze the activity of the components. So the primary results of this trial were presented in 2023 and show that amivantamab plus lazertinib improved progression-free survival, the first endpoint, when compared to osimertinib, with a hazard ratio of 0.7. We presented at ASCO 2024 the results of PFS in the patient subgroup with poor prognosis. For those patients with a history of brain metastases, AMI plus laser improved PFS when compared to osimertinib with a hazard ratio of 0.69. For those patients with liver metastases at baseline, the hazard ratio was 0.58. For those patients with p53 co-mutations at baseline, also a hazard ratio favoring the combination of 0.65, and for those patients with detectable EGFR mutation in liquid biopsy, also a hazard ratio of 0.68. So the key message from this presentation is that AMI plus laser improved PFS versus osimertinib even in the patients with high-risk features. During the World Conference in San Diego, updated overall survival was presented from this trial. And with this updated overall survival, we have seen that 61% of patients receiving amivantamab plus lazertinib were alive at 3 years versus 53% for osimertinib. This represents a hazard ratio of 0.77, and at this moment there is a clear trend, although it's not statistically significant yet. Other data that was updated from the trial was the intracranial progression-free survival. And again, the 3-year intracranial progression-free survival was 38% for those patients receiving the combination AMI plus laser versus 18% of patients in the osimertinib arm. The intracranial overall response rate was 77%. Again, amivantamab plus lazertinib show a favorable trend for intracranial duration of response when compared to osimertinib. It's important also that during the meeting, it was presented the first subsequent therapy. We can see that the proportion of patients that progressed and went on to receive subsequent therapy was similar between the two treatment arms. In amivantamab plus lazertinib, 72% of the patients received subsequent therapy. In osimertinib arm, 74%. And also the presentation about the time to symptomatic progression. And the time to symptomatic progression favored the combination of AMI plus laser compared with osimertinib with a hazard ratio of 0.72. During the World Conference, it was a presentation about the health-related quality of life information. So based on the URTC QLC3 tool, the patient-reported functioning was stable throughout the treatment compared to baseline. And this is important because the conclusion is that for patients treatment naive with EGFR mutations, amivantamab plus lazertinib delay the symptomatic progression versus osimertinib while maintaining health-related quality of life. And then another interesting presentation was the comparison in this trial between the osimertinib arm and the lazertinib arm, that, as I mentioned, the lazertinib arm was included to assess the contribution of components. Very similar results. The median PFS, according to the blinded independent committee review, was exactly the same for lazertinib when compared to osimertinib. Also, it was presented that for those patients with high risk, even no differences in PFS between osimertinib and lazertinib. And perhaps there are a slightly different toxicity with lazertinib. There are higher rates of rash and paresthesias, but in general, what we can say is that there are lower rates of treatment discontinuation, and it was exactly the same between the two treatment arms. Let's move on to updated information from FLAURA2 trial. So again, FLAURA2 was previously presented, is a study in first line in patients with EGFR mutations comparing osimertinib versus osimertinib plus chemotherapy, carboplatin, pemetrexed. The study also showed longer PFS for the patients treated with a combination of chemotherapy plus osimertinib, and also a trend toward an improvement in overall survival. So during the World Conference, it was presented the data of PFS according to the presence of p53 mutation, co-mutation at baseline. What the authors reported is that for those patients, p53 wild type at baseline, the median progression-free survival with chemo plus osimertinib was not reached. For those patients treated with osimertinib, again, was not reached. When they presented those patients with concomitant p53 mutations at baseline, the median PFS for osimertinib plus chemotherapy was 27.6 months, exactly the same when compared to osimertinib alone, 27.6, although the hazard ratio was 0.57. So the conclusion from the authors is that p53 alterations may be prognostic factor, not predictive. There was also a presentation from the FLAURA2 analyzing the impact of tumor burden on outcomes. And they defined two subgroups, those patients with at least 3 metastatic sites at baseline, and those patients with low than 3 metastatic sites at baseline. For those patients with at least 3 metastatic sites at baseline, the median PFS with osimertinib plus chemotherapy was 25 months, with osimertinib 16 months, with a hazard ratio of 0.57. For those patients with less than 3 metastatic sites at baseline, the median PFS for osimertinib plus chemotherapy was 27.9 months, for osimertinib 30.5, with a hazard ratio of 0.75. Let's move on to other third-generation EGFR TKIs that we have seen results in this group of patients with activated EGFR mutations. So again, a presentation during the World Conference in San Diego, comparing in the first-line setting rilertinib, that is a third-generation EGFR TKI, versus gefitinib. So this is a trial comparing in first line this agent versus gefitinib in a 2-to-1 randomization. So when we analyzed the results, response rate was similar, and the median duration of response was longer in the rilertinib arm, that was 20.7 months when compared to gefitinib, 11.1 months. You can see here, median progression-free survival, longer with rilertinib agent when compared to gefitinib, with a hazard ratio of 0.46, and also longer median duration of response with a hazard ratio of 0.46. Toxicity associated with relertinib, mainly diarrhea, the majority of cases, grade 1, 2, and also some liver toxicity, increase of ALT in 16% of the patients. This is a new agent, but probably very similar with what we have seen with osimertinib or lazertinib. I think it's interesting, a trial, the name is further with furmonertinib. This is an agent, is a EGFR inhibitor with a broad activity and selectivity across EGFR mutations. And we have also results of these agents in patients with EGFR exon 20 insertions mutations. But what was presented during the World Conference are the results of this agent in patients with EGFR mutations, but the mutations in the P-loop and the C-helix comprising mutations, the PACC mutations. These are uncommon EGFR mutations representing approximately 12% of all mutations and are located primarily in exons 18 and 20. So Dr. Blanchard presented the results of this trial, the further trial. These are patients, as I mentioned, with PACC mutations, and there was a comparison of two different doses, 160 milligrams and 240 milligrams. And I'm going to comment the results according to the blinded independent committee review for those patients treated with 160 milligrams, 23 patients, the response rate was 47%. The confirmed response rate was seen in 34.8% of the cases. For those 22 patients treated with high dose, 240 milligrams, the response rate was 81%, the confirmed overall response rate 63.6%. Interestingly, there are a small group of patients, 13 patients with CNS metastases, with brain metastases, and no prior treatment. And in this group of patients, furmonertinib was associated with a response rate of 46%. Toxicity associated with this agent, when we analyze the dose of 240 milligrams, we can see that dose interruptions were observed in 37% of the cases, dose reductions in 20% of the cases, and dose discontinuations in 5.2% of the patients. And treatment-related adverse events, grade 3 or 4, in 20%. And the most frequent toxicities include diarrhea and also rash. Finally, I would like to cover first-line setting in patients with EGFR exon 20 insertions mutations. We know that the Papillon trial presented at ESMO last year and also published in the New England Journal of Medicine established a new standard of care for patients with EGFR exon 20 insertions in first line. The combination of amivantamab plus chemotherapy improve the progression-free survival when compared to chemotherapy alone in this group of patients. What is new, and it was presented during this meeting, is the analysis of the progression-free survival of these patients with EGFR exon 20 insertion mutations according to the commutation of p53 at baseline. And overall, what was presented is that for those patients with EGFR exon 20 insertions and commutations of p53 at baseline, the median progression-free survival with a combination of chemo plus amivantamab was 11 months, with chemotherapy was 5.6 months, with a hazard ratio favoring the combination of 0.29. When they analyzed those patients with p53 wild type at baseline, AMI plus chemo was associated with the same PFS, 11.3 months, and the hazard ratio is 0.45. So in conclusion, these analyses show that in patients with EGFR exon 20 insertions, treatment naive, stage 4, amivantamab plus chemotherapy, prolonged PFS in both patients with or without concomitant p53 mutations at baseline when compared to chemotherapy. So in summary, I think we have seen a lot of studies that will change the standard practice. So now we have more treatment options in first-line patients with EGFR mutations. We have osimertinib, but also the combination of amivantamab plus lazertinib, and also chemotherapy plus osimertinib. So combinations in general, FLAURA2, Mariposa, improve progression-free survival when compared to osimertinib, and also in the two trials, we observe a trend towards an improvement in overall survival. So there is room to discuss with the patient the different treatment options. We have seen also new EGFR TKIs that are active in a group of uncommon EGFR mutations in patients treatment naive, and this will be object of further development. And finally, in patients with EGFR exon 20 insertions in first line, we have built from the Papillon trial showing an improvement in PFS with chemo plus amivantamab, and we have seen that this improvement is seen in the study irrespective of the presence or not of baseline p53 co-mutations. So thank you so much for your kind attention.
Hello, everybody. My name is Raffaele Califano. I'm a consultant medical oncologist and honorary professor at the Christie Hospital in Manchester and the University of Manchester in the United Kingdom. Today, I'm going to present you the latest clinical data for patients with advanced non-small cell lung cancer harboring EGFR-activated mutations who have experienced progression after EGFR TKI therapy. The first study I would like to present you is the Harmony study, which is a phase 3 randomized clinical trial which was conducted in East Asian countries, evaluating patients with advanced non-small cell lung cancer harboring an EGFR-sensitive mutation who had been exposed to prior EGFR TKIs and whose disease had progressed, and is evaluating a novel molecule called ivonescimab, which is an anti-PD-1 and VEGF bispecific antibody. Patients were randomized to receive standard chemotherapy with carboplatin and pemetrexed plus placebo, with maintenance pemetrexed and placebo, or the investigational arm, which was chemotherapy plus ivonescimab for 4 cycles, followed by maintenance pemetrexed and ivonescimab, with treatment until progression or intolerable toxicity. And the primary endpoint of the study was progression-free survival by independent radiological review. The study met the primary endpoint. In fact, there was a longer progression-free survival favoring the investigational arm, more than 7 months versus 4.8 months, with an hazard ratio of 0.46. With 52% data maturity looking at OS, there was a trend for prolonged overall survival also for the investigational arm. Looking at response rate, this was higher in the chemo ivonescimab arm at 50% versus 35%, and so was the disease control rate at nearly 93% versus 83%, with a longer median duration of response, again for chemotherapy plus ivonescimab. Looking at the adverse events profile, there were no unexpected adverse events with a low rate of treatment discontinuation, but there was a slightly higher incidence of grade 3 and above adverse events. The other abstract I'd like to present to you is an update from the Mariposa 2 study, which was presented at the ESMO Congress. Just to refresh your memory, Mariposa was a phase 3 randomized clinical trial evaluating patients with pre-treated EGFR mutant non-small cell lung cancer in advanced stage who had progressed after prior osimertinib and were randomized to 3 arms: chemotherapy plus amivantamab, chemotherapy or chemotherapy plus amivantamab and lazertinib. The data of the primary analysis was already presented, and what I would like to discuss with you is the very latest data on the overall survival that was presented with 75% maturity of the planned overall survival events, specifically addressing chemotherapy amivantamab versus standard chemotherapy. The authors reported a promising overall survival trend for amivantamab chemotherapy over standard chemotherapy alone, 17.7 months versus 15.3 months, with an hazard ratio of 0.73. And when you look at the 18 months overall survival rate, this was higher in the investigational arm, 50% versus 40% for standard chemotherapy. The authors also presented other secondary endpoints, and in particular, there was a longer time to symptomatic progression, a longer time to treatment discontinuation, a longer time to subsequent therapy, and also a longer PFS2 after first subsequent therapy. Based on the results of the phase 3 Mariposa 2 study, the European Commission now approved amivantamab plus platinum pemetrexed chemotherapy for the treatment of EGFR-mutant advanced non-small cell lung cancer patients following progression on prior EGFR TKI therapies. Another very important abstract is a phase 2 single-arm study evaluating a novel compound, which is PM8002 BNT327, which is a bispecific antibody which targets PD-L1 and VEGF-A. This evaluated patients with advanced non-small cell lung cancer which harbored an EGFR sensitizing mutation who had no prior systemic therapy other than an EGFR TKI. Patients were stratified according to PD-L1 expression in 3 main groups: PD-L1 less than 1%, 1 to 49%, and more than 50%. And patients received carboplatin pemetrexed chemotherapy plus the investigational agents for 4 cycles. And then they embarked on maintenance PM8002 BNT327 plus pemetrexed until disease progression. Being a phase 2 study, this was powered for overall response rate. But the authors also reported the activity of this regimen according to the PD-L1 strata. There was a response rate which was confirmed by investigator at 57% in the overall population. There was a clear trend with increasing response rate as the tumor expression for PD-L1 went up from less than 1% to 1 to 49% or high. So there was a clear incremental benefit with increasing PD-L1 expression. Looking at safety, there was a low rate of treatment discontinuation. The most incident treatment-related adverse events were low white cells, anemia, and neutropenia. But as we are rolling novel treatments and novel strategies in the first-line setting, a very important piece of information in clinical practice is what happens to the biology of these tumors when they're exposed to this new regimen, which are different than, let's say, first-line osimertinib. And at ESMO, there was a late-breaking aspect presented by Professor Besser, who reported on the mechanism of resistance from the Mariposa study. Notably, there were paired blood samples which were collected at baseline and the end of treatment for patients who, as part of the Mariposa study, discontinued treatment. Approximately 50% of the patients in both arms had matched ctDNA data. And what the authors reported was that for the amivantamab lazertinib arm, there was a lower incidence of MET amplification or EGFR resistance mutation. There was a numerically lower incidence of p53 mutation or p53 and RB1 loss of function, which is usually associated with small cell lung cancer transformation, but they didn't report any significant difference in the incidence of other pathway and mechanism of resistance, such as HER2 amplification, PI3 kinase, RAS activation pathway, and so on. So clearly, if you use a regimen such as amivantamab and lazertinib, which is part of the Mariposa 2 study, this is changing the biology of the acquired resistance due to very select inhibition of EGFR and MEF pathways. If we want to compare what happens at the biology of the tumor after exposure to chemo-osimertinib, which was the winning arm of the FLAURA2 study, there was data presented at World Lung Cancer Conference which showed that for patients who were randomized to chemo-osi compared to osi monotherapy in the FLAURA2 study, but also historically to the osimertinib arm of FLAURA, there was actually no difference in terms of acquired mechanism of resistance when looking at plasma samples. So to summarize, a lot of data on the EGFR mutant space has been reported over the last few months at major congresses. I think the treatment paradigm is changing very quickly with novel regimens being brought to the frontline setting, and therefore it's very important to understand how to address these patients in the second-line setting, and also how to use the change of biology and understanding of the mechanism of resistance to maximize efficacy and spare unnecessary toxicity. Thank you very much, and thanks for joining us.
Hi, I'm Antonio Passero. I'm a medical oncologist in the European Institute of Oncology in Milan, Italy, and I welcome you to this third chapter discussing the development and the innovation for patients with EGFR-mutant non-small cell lung cancer. In this chapter, we'll discuss the advent and the new strategy for our patient, in particular the subcutaneous injection for antibody. So as you know, the use of antibody is under development to try to reduce the tumor burden for patient and healthcare system. And as you know, we have a very, very interesting data confirming the use of subcutaneous injection for patients without driver candidate to receive immune checkpoint inhibitor, for example, atezolizumab. And today we'll focus on data about the use of subcutaneous injection for amivantamab, a bispecific antibody able to use to help patients with EGFR-Mutated non-small cell lung cancer. Amivantamab was approved for the first line in combination with lazertinib for patients with mutant non-small cell lung cancer and common disease. And also, amivantamab is approved for patients with exon 20 insertion mutation first line in combination with chemotherapy, and on second line for patients with common disease progressive on or after osimertinib in combination with the chemotherapy. The development of amivantamab started for the evaluation of subcutaneous injection with the PALOMA-2. The PALOMA-2 is a multi-cohort trial evaluating the combination of subcutaneous amivantamab in different kinds of cohorts. In the Mariposa cohort, so naive patient in combination with lazertinib, in the Papillon cohort in combination with chemo, also in Mariposa 2 cohort. But today we'll focus on the results of amivantamab subcutaneous plus lazertinib in the first line of EGFR-Mutated non-small cell lung cancer using data from the PALOMA-2. Here we can see that the use of subcutaneous injection confirm in combination with the lazertinib an over-response rate like the IV drugs with an investigator assessment over-response rate of about 77%. And this, of course, is a great news confirming the preliminary efficacy of this new formulation. Particularly when you focus on the safety profile that was evaluated in different cohorts on the PALOMA-2, we can see that globally the different kind of toxicity was more or less the same, but the key factor for the subcutaneous injection was the significant reducing rate or infusion reaction in this particular setting. Also, the rate of VTE were low and most grade was 1 on 2. Globally evaluated the safety profile in the PALOMA-2, this kind of signal very strong, confirming the potential improvement in the trials of subcutaneous injection. The PALOMA-3 trial is a randomized phase 3 trial evaluating patients with non-small cell lung cancer, harboring EGFR mutation, progressing after osimertinib and platinum-based chemotherapy, so in third line, that were randomized with a ratio 1:1 to receive subcutaneous amivantamab plus lazertinib versus IV amivantamab plus lazertinib. The primary endpoint for this kind of trial was to evaluate the non-inferiority of diffusion. Globally, subcutaneous amivantamab found to be non-inferior to IV drug in the PK and also in over-response rate in this kind of heavily pretreated patient, confirm an over-response rate of 30% for sub-Q and 33% for IV. But globally, it's very, very interesting to underline that the duration of response was longer for patients that received sub-Q formulation, 11.2 months versus 8.3 months for IV. And also the progression-free survival was 6 months for patients with subcutaneous injection and 3 months for IV drug. This is a very, very interesting message confirming that the subcutaneous injection is effective and, of course, non-inferior to IV, potentially better consider the mechanism of action. And also, when we focus on the data, we can see that there was a significant improvement in overall survival with an odds ratio of 0.62 for patients that was in intention-to-treat population. Globally, I think that the most interesting significant data also coming back from the safety analysis. When we focus on the safety profile, we can see that the subcutaneous injection was consistent as a safety profile with IV, but we focus and we identify very fewer infusion reaction. So more or less 13% versus 65%. And also VTE, there was a key toxicity for the combination, was 9% versus 14% for patient candidates to receive IV drug. So globally, this is a very good news. Also because infusion reaction led to sometimes hospitalization with sub-Q, this number of events was lower, and the infusion reaction related to discontinuation was 0 for patients that received sub-Q versus 4 events in IV treatment arm. So when we focus also in this other secondary point, we can see that the treatment administration time was shorter for sub-Q versus IV, with less than 5 minutes, so very fast, compared to the standard infusion for AMI, and about 2-5 hours respectively, according to the infusion time and cycle days. And this is important because also patient-reported convenience, that was of the secondary endpoint, showed a more patient-reported increased convenience with sub-Q versus IV, and the specific number was 85 in favor of sub-Q versus 35 in favor of the other formulation. Also, the healthcare resource utilization was in favor of the combination with the sub-Q, so we can see that globally the treatment was a very good formulation, both for patient and also for healthcare provider, nurses and doctor in this particular setting, in considering because there was a very short time for injection that was very useful to improve the quality of life and the patient experience during the time. And this is very clear when we focus on the patient satisfaction, preference, recommendation, and it's clear that the patient satisfaction was very high in favor of sub-Q versus IV drug. Globally, I think that the data that I presented earlier about the use of amivantamab, a sub-Q formulation, are very exciting, considering the perspective to use this kind of drugs in combination with the lazertinib as a new first-line treatment in a field very, very exciting, where today we have many options for our patients. Thank you very much for participating in this activity.
This program was presented by Medscape Education Global.